Simon, many thanks for meeting with me. I was told that you get a very stimulating, inspiring talk at a meeting recently, and I was curious enough to ask you if I could come along and hear the same message.
Okay.
So I'd be grateful if you just could give me an idea of what it was that you told that meeting.
Absolutely. So, as way of background, my name is Simon Tulloch. I'm Head of Quality, Innovation and Patient Experience at East London Foundation Trust. And the other week I was asked to give a 5-minute presentation on the use of patient outcome, patient feedback data in the Trust. And I'll start now as I did then, which was to give a little bit of history. So the Trust has a reasonably kind of long history of getting patients and carers involved in feedback across the quality and experiences of services that they've required. About 5 years ago, a team of people participation leads in the Trust worked with a team of patients and carers to develop a set of standards that they would expect for the provision of, this was focusing on inpatient mental health care. So they worked to develop a set of 10 standards that they felt all inpatient care should reach. They then developed a set of questions, 2 questions per standard, for the assessment for patients to make and carers to make of whether they received that good quality care. So these standards were developed. They were known as the Service User-Led Standards Audit. So in addition to having service users and carers developing the questions, developing the standards, the kind of third and kind of more empowering or interesting element was that service users were involved in the collection and analysis of that data. So the questions were given to trained service user auditors to go into inpatient wards, to speak with people who are currently on those wards, to ask them about their experiences of the service. Now, this process has been ongoing now for around 4 or 5 years. It happens every quarter and is a very good way of ensuring that you have reduced the element of bias, if you like, when you're collecting the data, to get more honest responses from people, and it's a good way of tracking change over time. And what we've seen is that as we've implemented a number of changes to improve the quality of care and treatment in our inpatient wards, we've seen those scores improve over time. So this is the first step in setting up a kind of robust patient feedback system. The kind of next step is obviously to move into a more digital age, and what we've done is we've first of all we have tested things such as digital pens to collect data. So it's still a kind of a pen and paper basis, but then the data is being transferred automatically directly into our server, and we then generate charts, if you like, for both the local teams, the wards, to see the results, and also for service users and carers to see the results, and also for the Trust board and commissioners to see the results. And because it's on the board, it's also publicly available, so we put all of that information on the Trust website so people can see the results and how they've changed over time. The next step is obviously to move into a more real-time process. So we've developed a system whereby we can collect patient-reported experience and outcome data using either handheld tablets like iPads or something similar to that, touchscreen kiosks, which are very common in GP practices and all sorts of places, whether it's pharmacy or Tesco, wherever you go now, you see these things, or to use online feedback systems. So we give people a link to an online. So those are the kind of more up-to-date electronic real-time measures. What happens is that the data now is coming directly into our server, our data warehouse, and populates the dashboards that we produce. Now, these dashboards contain a whole range of information, not just the patient-reported experience and outcome data, but things such as length of stay, bed occupancy rates, medical errors, whatever it may be. There's a whole kind of range of information in there. So the patient feedback data sits alongside that information, so that each team, each ward, each directorate, because this trust covers 3 boroughs, City and Hackney, Tower Hamlets and Newham, they can see the results at whichever level they need to see it, ward, borough, or across the whole directorate. And that data comes through real time, and it's generated through this dashboard, if you like, and the clinicians can then make decisions, review the data that's there at either a weekly or a fortnightly review meeting to see if any of their clinical practice needs to change. And this is where it fits in with a large-scale, trust-wide quality strategy. So as a trust, we have recently developed a quality strategy which has a 7-year target. So by 2020 we have the aim of being the highest quality provider of mental health and community health services in the country, and we're working alongside IHI to do that, who are an American organisation who've worked with NHS Scotland, NHS Wales and various trusts around the country and other medical services around the world to use a very structured quality improvement methodology. So the idea is we have all of this information and it's used to make changes and track change over time, so that when clinicians and teams and directorates and trust board are reviewing the data, they can identify where changes need to be made, try the change, have a look at the data after a certain amount of time and see if it's made any difference, and have this continuous cycle of quality improvement. The patient experience data is vital in that. It's one of the central pillars of that process, because it might be that we're getting excellent results across a number of metrics, but actually if the patient feedback is getting worse, then we're going wrong. So this is how it fits in. Now, in terms of working with our commissioners on this, the sequence, which is commissioning for quality and innovation, is a, if you like, a financial element to identify innovative ways of working and try and improve the quality of the service that you're providing. We work with the commissioners to develop these sequences, and they could be across a range of areas. Now, in reference to patient experience data, the sequence have been used to test out these different methodologies that I've described, whether it's using the electronic devices or trying to collect, use the service user auditors to collect data from other settings and for different kind of areas of interest, whether that's around medication or ward rounds or food quality or hygiene, all sorts of different areas. So that's been used as a driver, and it's useful in that sense. And as a consequence, I think we as an organisation have a pretty robust, there's always room for improvement and we still have plans for the future, but a pretty robust system for collecting, collating and using the patient experience data that we collect. As I say, it's a central pillar to quality improvement. We have service users involved at all stages, so all of the questionnaires and surveys that we developed are developed in partnership with service users and carers, and if they're not happy, they will let us know, and quite rightly. They're the people that we're serving. So we've got service users and carers involved, and all of the data that we produce is publicly available. So the dashboards that I mentioned, which have clinical effectiveness data, safety data, patient feedback data, staffing feedback data, they're available on the Trust website so that any organisation can see what our data are saying at any given time. So I think in that sense we have a robust system, we're involving service users and carers, and we're transparent. Our data is publicly available.
Very interesting. The people, the service users who you have trained up to be, what do you call them?
Auditors.
Auditors. Are they paid to do this, or is it a kind of volunteer basis?
No, we pay them. It's the system is such that in essence, the principle behind it is trying to empower service users who may have gone through a great deal of change, struggle, stigma, in particular with mental health, and the service user auditors are actually one element of a much larger organisation or element of the trust, which is called Florid. So this is a service user led and managed organisation which sits within the trust, if you like, but it is managed by a former service user, staffed by service users, and that involves placement around the organisation. So on any floor of the trust headquarters, you will have service users or former service users who are working. Now that could be to gain experience, job experience. It could be to have to improve their communication skills, their confidence, their self-esteem, and the service user auditor project is just one of those streams, if you like. So the idea is that we have a couple of days where we work with these service users who are interested in auditing. We give them skills around how to use the technology, around confidentiality, around information governance, the kind of important elements, so that they feel confident and able to go into either inpatient wards or any of the services and understand the system or the environment that they're going into, and to feel confident about sitting down and speaking with current service users. There's a very powerful element to that, which is for those people who could have been on an inpatient ward for however long, a month on an inpatient ward, to have then been discharged back into community care, whether it's a CMHT or whatever it may be, to then develop the skills and feel confident enough to go back in to a ward where they may have been a patient with these new skills, and to sit down in a new role. And it's not necessarily an authority role, it's a role of empowerment and collecting information and feeling valued. So it's a really important kind of principle. But what it also means is, and I mentioned this at the beginning, is if I were to go into an inpatient ward and sit down with people and ask them questions about the experience that they've had with my ID badge and being very formal, they're less likely to be as honest with me as they would be with somebody who is a peer. And that's a really powerful element as well. So it means that the information that we get back from this system, we feel we have more confidence in it. And what we also find is that we get a very good response rate using this system. Alternatives, say for example the national patient survey that we have only for the community sample at the moment of people who use community services. We don't use it for inpatient services for obvious reasons, because we have this system. We get a pretty poor response rate. Now that could be for all sorts of reasons. We obviously know that within our area language may be an issue, but it may be because people don't feel particularly motivated because it's anonymous in that sense. It's just a questionnaire that's been posted to them. Whereas if it's a service user who sat down with them and say, yes, I remember being here a year ago or 5 years ago, I'm now working as part of this service user auditor system. We're trying to collect information from you to understand your experience, which will then be used to improve the quality of services. So as a continuous cycle, you have a better chance of getting a higher response rate, and that's what we find. We have a very good response rate. But it's a really good system. Now, I mentioned also that we're looking to move forward and try different options for getting feedback, and that could be things such as using text messages, SMS, to get feedback, more kind of online options, or possibly via our Facebook page or by Twitter. So we're trying to embrace the various avenues that technology allows us to get the feedback data and make sure that it's all going, as I say, into our, what we call the data warehouse, so that we can then, if you like, pull it through there and put it onto our dashboards. So it's all in one place. So yeah, we're trying all sorts of different options. The obvious thing to say about those options that I've just described, whether it's Twitter or Facebook, there's less of a role for the service user auditors in that, because in essence you're using an electronic medium as opposed to the human medium. Now, what we know as an organisation actually is that people like to have that one-to-one contact. So aside from everything that I've just described, as a trust we have been involved with NHS England as one of the pilot areas for the Friends and Family Test, the FFT. So we're now engaged in the second phase of this pilot, but the first phase was to see whether we could get the FFT question from people who are using mental health services in patient wards. We were reasonably confident we could do that because of the other data that we were already getting, the service user-led standards audit. The second phase, which I think is far more interesting, is whether we can link people's responses when they are either transitioning between services, so that could be people who are going from child and adolescent mental health services, CAM services, into adult services, so that we get information about what it was like in CAMS, in the transition period, and then in adult services. People who are transitioning from secondary mental health services back to primary care, to GPs, so we get their experiences of transition. And then for us, the third arm of this particular piece of research that we're doing now, which is far more complicated, is those people who use services by multiple providers. So, and we know there are many people who use mental health services, physical health services, and primary care. Classic example is somebody who may be using the clozapine clinic, may also be in contact with the community mental health team, but may also be in contact with diabetes services or foot health in community health services, and may well be in contact with their GP. So what we're trying to do is link the patient experience data, specifically the FFT data, from each of those different services. Now, in essence, what that means, stating the obvious, is that you need to be able to identify people. Now, one thing that we're testing is whether we can use the NHS number as a means of tracking those individuals. Now, that then throws up a couple of questions, certainly around the anonymity, which in the kind of scenarios that I described before, it's all anonymous data. If you're able to identify people, then that anonymity is obviously lost, and people may feel less likely to respond. So that's something that we're testing. So that's a negative to this scenario. The positive is that obviously we can then track or see what their rating is of each of those different services. So if they go to the clozapine clinic and they have a really excellent experience and they feed that back, that's great. Yet they go to the CMHT and it's less good, then we've got the direct comparison, because the individual is the control, if you like. But then if we can also compare that to community health services or general practice, then that's really interesting, and we should, in theory, be able to do that and share the results with each of those providers. Now, we're testing that, as I say, in East London, and we're focusing the test in Newham, because we happen to provide both mental health and community health services in Newham, so it's slightly easier. It's still complicated by multiple patient data systems, as we're all aware of, but we think it's doable, so that's something we're testing at the moment. So there's some interesting things. Now, the next level to that is whether we can also collect patient-reported outcome measures, which are relatively new in mental health, been around in all sorts of other health areas for years, but relatively new in mental health, and seeing if we can link then the PROM and the PREM with patient identifiable data, because then we can see, we can look at all the other demographic information as well. So that would be very powerful if we could do that. So that's another thing that we're testing. So there's lots of things on the horizon, that we don't know about, but we think it's possible to do. As always, there's a few technological issues to deal with, but I think we can get over them. And one of the things that may help that is working with our commissioners around funding that appropriately, whether that's through Sequins or something else. That's one of the things that we're looking at right now.
So the patient experience, the auditors and so on are checking. This is on inpatient.
At the moment, it's inpatient.
So outpatient, say, my patient goes to see the consultant, and outpatient, is that also?
So at the moment, what we have is touchscreen devices in reception areas. So that's how we're getting our feedback there. So the service user auditors aren't there because the option would be either...
You're getting feedback though.
Oh, we're still getting feedback, but it's not necessarily on that face-to-face.
Okay.
Now, one option could be, and this is something else that we're looking at, is using a peer support model. Now, you may or may not be aware of the peer support in mental health. Now, again, it's similar to the service user auditor model that I described. It's people who have used those services, who are no longer inpatient users. They're in contact with community mental health services. They become peer workers, if you like, support workers, and help people in that transition from inpatient to community services. Now, it could be that they could also collect some of that feedback data so that we've got that continuous bridge into community. So at the moment where we just have these touchscreen kiosks in our CMHT reception areas, we actually have that face-to-face element again. So that, again, that's another thing that we're looking at for the year ahead.
Now, do you collect data or feedback from staff?
Yes.
Okay, so for ward staff,
so the
psychiatrists.
Absolutely. Yeah. So there is a national staff survey, which is an annual survey, which is quite a large survey, covers a whole range of areas, whether that's around training or supervision or health and safety or the hours you work or whatever it may be. And as a trust, recently our response rate is pretty good. In the past it hasn't been so good, so it's taken a lot of work to try and get our response rate up, and one of the reasons that we've increased our response rate is that we've moved from pen and paper to electronic, so people can complete it online, either at home or at their computer at work. Now, the problem with an annual survey is by the time you've got the data, and this is via an external organisation, so we're not in control of the data collection, by the time you've got the data analysed and the report sent back to you, it's at least 4, if not 6 months old, if not longer. Then you've got to act on it. It doesn't, if you like, squeeze into our data warehouse, so we can't use it in the same way that we would within our dashboards. So to ensure that we get more reliable, more regular feedback from staff, we have just this year established a quarterly web-based feedback system, so that we will get the Friends and Family Test question, which for staff will cover both whether they would recommend working at that service and whether they would recommend being treated at that service. So there's 2 elements to the staff question. But we've also got 4 additional questions, which those questions are based on the results from our annual survey. So where we haven't done so well, or where we think we would like to improve most, we've added a question. So whether that's around supervision or training and development, there are questions in there. So what we're doing is sending out an email, and it's, I think, to a quarter of all staff across the trust, which is just under 1,000 staff. They will be asked to feedback every quarter, so that's every 3 months, on the 2 Friends and Family Test questions and the 4 kind of local questions, so that that data can then go into that dashboard and be used more regularly. The staff feedback data that currently goes into the dashboard are things like staff vacancies, reasons for leaving, vacancy rates, feedback on complaints and things like this. So we still have staff data going into that dashboard, but it's not necessarily direct staff experiences or perceptions. So that's one of the areas of improvement for this year, 14-15.
And then coming back to the inpatient feedback system, I mean, obviously you show the data, the feedback to the ward staff.
Absolutely. So they get it. The way that it works is that on their computers they can access a whole raft of data in these dashboards, and for us it's called reporting services. So they can literally click and see the data specific to their team, or even on a consultant level, to review that during their team meetings.
Right. And you said this data, this dashboard also is available publicly?
Publicly.
Okay.
It's on the Trust website.
Okay. Now, how do the staff feel about this? I mean, because obviously this could be quite threatening at one level.
It's an interesting point. I think
it's a good idea.
Yeah,
but there is this.
Yeah, the Trust as an organisation. I mentioned the quality strategy at the beginning, that we have an element of the quality strategy is about transparency and making sure that all staff are aware of all of the information, and the public is aware of the information. We're not trying to hide anything from anybody. With that information, with that data, you can then be informed about the choices that you're making. So as opposed to it being threatening, we're trying to encourage the culture of it being empowering. Inevitably, there will be people who feel a little bit threatened, but that, I think, is something that will be reduced with time, through experience, and by seeing evidence of it being used positively. So that's something that we as an organisation, as a kind of corporate team, have to push forward. So that's an important role, if you like. But yeah, there will inevitably be a few people who feel a little bit threatened by it. All we can do is try and encourage the use and encourage the principle of it being an empowering tool and not a threatening tool.
And do teams then look at the data together?
Yes.
And kind of think about
absolutely. So each ward or team or service will either look at that data on a weekly, fortnightly, or the largest period would be monthly, and that would be at each level, ward, DMT, borough level, so that they can then identify, as I mentioned, which areas are key priorities for change, for trying to implement an initiative, a quality initiative.
Okay. Well, I think that you've given a very rich picture of this, and I feel quite jealous in the sense that in primary care we don't have really much resource or time to look at what we do, and and in a way you're somebody who's your title of your
head of quality, innovation, and patient experience.
Yeah, well, I'm not sure. We don't have such a person.
I understand.
We don't have, it's an interesting question. How do we have such a process in place? I mean, because I'm here because there's this question on quality in general practice. Well, how do we assess it? What criteria or standards will be adopted and all the rest of it? But then what kind of time is there to do the collection, and what is the time for reflecting on it? Where's the training to support the GPs and the nurses and so on to actually deliver this, and so on? So it's a big, there are lots of questions.
Absolutely, yeah. And I think there are many people who work on this across many teams, and it does take a great deal of time. This isn't something that we've just knocked up in the last week or two. This has taken many years, and this is far from the finished article. There's still a huge amount of work to be done. in response to your comments, whether there's potential for partnership working and resource sharing, that may be an option. But yeah, from our perspective, I think it's worth investing up front so that you have the information, because it then, as I say, empowers the clinicians at the front line to make changes based on solid, robust, reliable information.
Yes, I agree. Thanks a million, and I'm sure we'll have further conversations.
Pleasure.
Thanks.